We're rolling.
All right. Well, we lost our guiding slides.
I know.
But,
sorry, more technical difficulties, but this is a really good topic because the literature's been all over the place. From do everything to do nothing, and now we actually got some real
Guidance.
scientific guidance. So, topic today is subclinical hypothyroidism. So you want to start with your case?
Sure. So, and I think this is pretty common. We have a 71-year-old lady. She comes in with complaints of fatigue and depression. She has hypertension. She had a heart attack 4 years ago. She has a history in her family of autoimmune thyroiditis. Her exam's kind of unremarkable, and you wind up with these in-betweener lab tests, which sort of define subclinical hypothyroidism. She has a TSH that's slightly out of range in terms of being high and a free T4 that's normal. And the question that she wants to know is, would she benefit from levothyroxine therapy?
She just read in Ladies' Home Journal that levothyroxine therapy makes her less fatigued and helps her lose weight.
Exactly.
That's typical.
But in this case, maybe she read the New England Journal because they had a big, they had a big
that was
article.
after the Ladies' Home Journal.
Exactly. They finally caught up. So the prevalence of subclinical hypothyroidism, which is defined as this pattern of an elevated TSH but a normal free T4, is about 3% of the population. A TSH less than 10, they use 10 to define in the past severe disease, is 75% of cases. And interesting, if you have a TSH of 7 or less, over 2 years, most of those people, about half, will have, when you repeat the testing,
Will normalize.
Will normalize. We know a TSH greater than 10 is associated with more likely to have symptoms attributable to thyroid disease and more likely to have cardiovascular events,
Right.
although not well defined because all based on meta-analysis.
And not understood why.
Yeah, and then the annual risk of going from subclinical to overt hypothyroidism is around 2 to 6% when you take all comers.
Yeah, and I think something that really changed my practice is understanding there's a pretty good differential for hypothyroidism and causes and workup, but in subclinical, when it presents in a subclinical manner and it's going to progress, it's almost always autoimmune, which actually affected how it changed my practice.
Yeah, because I used to think thyroid antibodies.
I never ordered those.
I didn't either.
I thought that was for endocrine, and what were they going to do with them either?
Now I'm going to have to find out how to get them ordered. Actually, they're a thyroid panel in the CPRS. So.
There you go.
Should we talk about symptoms? So what do people present with?
Hypothyroidism.
I heard 9 non-specific. And I think that's absolutely true. Because when do we tend to get these things? These labs?
When the patient is complaining of fatigue.
In the hospital.
Fatigue.
Yeah,
weight
heart
gain,
failure patients
hair loss.
hospitalized.
Exactly. Weight gain, all these things. So it's really,
Things that people have anyway.
yes, exactly.
That's the problem.
Yeah, and I think that makes it hard to study.
Yeah, I think the nice point from the article is that you know how we always have, here's your standard results and here's your abnormal if you're not within that range. Well, in in thyroid function, for people, we range widely from where we live normally. So, but we've got these kind of cutoffs that drive things. So that's why repeating tests can really tell you, oh, that person, they just live there.
Yeah.
And if they don't have the antibodies, and that's normal for them.
Yeah.
So, but nobody's going to quite fit that little fingerprint of the standard results. So I think that's an interesting fact. So.
And there's some question about reference ranges when you get older. There was even a study that said it was an observational thing. They couldn't repeat it, but at least one said that, gee whiz, if you're over 85 and you have subclinical hypothyroidism, you might walk faster.
Yeah.
than if you had normal thyroid function.
Right, it might be physiologic, like
Yes.
the SED rate, right? Everybody's SED rate goes up as they age, and so we haven't done a lot of studies to look at. Usually our standards are set up in young, healthy people, and yet that's not who we're treating.
Yep.
So it's a very interesting evolution, I think, of thought. So.
Yeah, and I think some of the things, like one of the things that helped me think about how hard this is to parse out, they said, gee whiz, we see that when the TSH goes up, the free T4 is still normal, people gain weight. But it turns out when we put them on replacement therapy and bring that TSH back to normal, the weight doesn't change.
The Ladies' Home Journal is wrong. What is interesting though is weight loss actually will cause people's TSH to decrease.
Mm-hmm.
And I found that interesting.
Yeah.
So there's like a lot of interplay that we're really trying to figure out. Thyroid's been, we thought we understood it well, but there's a lot we don't know yet. So.
Yeah. So this pattern of test results, what's the most likely thing, typically, that they could explain this other than, gee whiz, they have subclinical hypothyroidism? What else could it be? Is there another explanation other than just put them in the subclinical hypothyroid bucket? I would invoke rule number 1 of medicine. It's early in the year, so I can do that.
Iatrogenic.
Right.
No, Dr. Norris. So helpful.
Iatrogenic is a
that's-
rule number. Oh,
it
I
is
thought you were
number-
making
wait,
fun of Dr.
no,
Norris.
I
Okay.
am. Rule number 1 is if you don't know it's a drug or a virus.
You've caused it too.
Yes, okay, so that falls. So
Yes.
the pattern of thyroid test could be due to a medication,
Like amiodarone.
amiodarone, lithium, or maybe they're taking levothyroxine. This would be different, but if they're taking levothyroxine, maybe they're taking it incorrectly, not on an empty stomach. This medicine's pretty sensitive to absorption.
Right.
They're taking it with iron,
Right.
and then recovery from non-thyroidal, from another illness.
Yeah.
So like a viral illness,
Hospitalization.
hospitalization.
That's why testing people when they're in the hospital maybe isn't the
Yep.
most wise thing to do. Unless you get a TSH of 50.
Yeah.
That's what we're looking for.
Exactly.
But this is what we find.
Yeah, all the time.
Right.
And then follow up primary care
Input.
provider.
Yeah. Our favorite statement.
Exactly.
So I think that, again, kind of going back to this, when you have a high TSH, less than 10, and a free T4 that's normal, checking autoantibodies can really help guide what you're going to do next.
Mhm.
Because those are the people that are actually going to probably progress to true hypothyroidism.
Right, they have twice the rate of progression.
Yep.
And I think one of the things we should ask ourselves when we go into treatment is, what are our goals of treatment and what are we hoping to get?
Mm-hmm.
Because the article, most of the patients had a TSH around 7, and they looked at fatigue, quality of life, these sort of things. No real differences.
Right.
There is some suggestion on meta-analysis that there's a linear relationship between cardiovascular events
And stroke.
but it's not clear
If treatment reverses.
if treatment reverses anything. So you could make that case.
So I think really what the point of that article was is that what you want to do then is actually follow a lot of people till they fall into a little bit more of a bucket where treatment may help.
Right.
So the guidelines are that if people have that range of less than 10 on their TSH and a normal free T4, that you would repeat that test in 2 to 3 months. And then you're going to see, is there progression? And at that time you can throw in the antibodies to thyroid peroxidase and see if there's antibodies to thyroid peroxidase, then those people should get tested every 6 to 12 months because you're almost sure they're going to go to hypothyroidism and then actually benefit from treatment.
Right. With a caveat being that if they're over 70,
Mm-hmm.
they're less likely to benefit.
Yeah.
And if you're on the fence about, let's say you have somebody that's younger and you're pretty convinced that
Yeah.
that they would benefit from treatment, it's not wrong to
Right.
do a trial, but reevaluate them. I think it was at 6 months.
6
they said do
months.
6 months and then.
That's where it's wrong, is to not reevaluate.
Correct. Yeah.
Because you're going to see, did their symptoms get better? So somebody that maybe is fatigued from depression or sleep apnea, you missed their sleep apnea or something, and they're not better, then you're probably causing some harm with that levothyroxine. Because really, with that TSH of less than 10, you're still not giving them a ton of benefit. I do think the article said, and I think this is the art of medicine, so when you're over 70, if you're healthy and you've got cardiac risk factors and you're over 10, then those are people you can also consider treating.
Yeah.
Because it does affect your LDL. It does lower your total cholesterol, your total LDL, and it's theorized that's how it helps with prevention of stroke and cardiovascular events. So.
Yeah. And then as far as one thing I got out of it that changed, I always thought, gee whiz, if you're over 60, what I was taught was no more than 25 micrograms, and you have to work up incrementally.
Mhm.
And they kind of said in the article, you can, based on how severe you think the symptoms are, as long as they don't have unstable
Right.
angina
If
or
they don't have it.
uncontrolled AFib or something, you can probably do 50 to 75.
60 is the new 40, baby.
Exactly. Exactly.
I can say that with comfort more and more.
Exactly. So I think that's
Yeah, you want to wrap up your case? What would you
sure.
do?
So yeah, what would you guys do? I think there's really two ways to go. Is based on
Repeat
the
testing.
So she's 71.
she's 71, so she's over 70, so her chances of benefit are lower.
She has had an MI.
She does have coronary disease, and we don't know what her thyroid antibody status is.
But she does have a family history positive for autoimmune thyroid.
Yeah.
So what would you do next?
Text-
She's 6.9 and free T4 is normal.
Get an anti-TPO.
Yeah.
Okay. I think
I think
that's
that's reasonable. Check an antibody.
Yep.
Yep.
I think check an antibody and then follow up labs in 2 to 3 months. And I also
Yeah.
think that I think if you know this person very well and you're fairly convinced, have them do a trial.
Yeah.
And I'd probably put her on probably no more than 50 because her labs are really not that abnormal.
Yeah.
And then see her back in 6 months. And I would say, maybe this is an art of medicine or birchism, but when you have things...
Art of medicine or birchism? You
one being good, one being bad.
Oh, okay. I thought you were like,
They're
you know.
both art.
But I love
He's
the
like Hippocrates.
I love the symptom diary
Yeah.
because I think in these people, this stuff we're talking about repeating labs like in 6 months, and if you're giving them a medicine, the symptoms kind of come along gradually,
Yeah.
and so I think unless they kind of try to document how they feel,
That's true.
you may not, they're just recalling and saying, I think it's helpful, maybe it is, maybe
Right.
it isn't, and so I think I would at least, if I'm going to have them do a trial of medicine, I would ask them to try to chart, maybe just 2 to 3 times a week, how they're feeling, and then compare that after
Yeah.
they've been on therapy for a few months.
I think that's a good birchism.
Because they recommend,
change.
yeah, for a change.
For a change.
Because they did say if you do the trial, don't just do it and then leave them
Right.
on it. Like, stop it if they're not getting benefit.
Right.
It's a pill that they're going to take the rest of their
Right.
life.
And they said even in people you're treating and who benefit, they did a big chart review in these meta-analysis, and they found a lot of people aren't getting their TSH monitored, and they
Mhm.
stay hypothyroid for the average is like
10% in
yes,
5 years.
10% at 5
Terrible.
years. That's pretty bad.
Yeah, it's terrible.
Then you're
diagnosis.
actually causing harm.
Yep.
So, yep. All
Okay.
right. That's
Sounds
it.
good.
Thank you.